Today's topic is nursing management for clients with increased intracranial pressure. This will be an important concept to understand for many of the neurological alterations. So let's talk first about the cause of increased intracranial pressure. Some neurological conditions can cause an increase to intracranial pressure. Cerebral edema is an increase in volume of brain tissue due to increased capillary permeability, otherwise known as leaking of the fluid from cells into the tissue, changes in functional or structural integrity of cell membranes, or increased interstitial fluids. The effects of increased intracranial pressure are proportionate to the size of the injury and may be localized or broader. Some of the causes can be from a head injury, diseases such as bacterial meningitis, prolonged seizure activity, stroke, and brain tumors. Even benign brain tumors can be deadly due to the limited amount of space for tissue swelling. The cause of increased intracranial pressure is directly related to an underlying pathology. Increased intracranial pressure cuts off blood supply to brain tissue, and without oxygen, the brain tissue will die. Depending on the extent of injury is the resulting tissue death, brain damage, and functional impairment. Use this link in this PowerPoint for more in-depth understanding about increased intracranial pressure. Now let's talk about the physiology of increased intracranial pressure. Increased intracranial pressure is not a disease, but rather the fallout from an insult to the brain. In adults, the intracranial compartment is protected by the rigid skull, which houses a set amount of internal fluid. Shifts to accommodate extra fluid will produce neurological deficits because of the squeeze on the tissue and consequent blood supply to the involved brain tissue. Prolonged pressure above 15 millimeters per mercury is considered to be increased intracranial pressure. Normal intracranial pressure is between 5 to 10 millimeters per mercury. Normally, you and I can have an occasional transient elevation in our intracranial pressure with physiological events like sneezing or coughing, bearing down with bowel movements, and so forth. In the short-term event of increases in intracranial pressure, the brain can usually accommodate. So now let's talk about the manifestations of increased intracranial pressure. Regardless of the cause of increased intracranial pressure manifests signs and symptoms based on the location of where that actual injury in the brain is and to the actual extent of the tissue that's involved in it. The earliest signs, and again this is a key element to remember, the earliest sign of increased intracranial pressure is a change in level of consciousness, where the patient was alert 1 minute, you go back to assess, and now the patient is confused. Clients can also complain of a headache, vision changes, nausea, vomiting. Speech and facial muscle innervation can be impaired due to an injury, insult into the brain, and cause aphasia. Pupillary changes can occur, in particular dilated or constricted pupils that are non-reactive to light. Changes in motor or sensory function, cranial nerve changes, ataxia, seizure activity, hypertension, and abnormal posturing. Cushing's triad is a response to increased intracranial pressure, which includes 3 prominent signs of imminent deterioration. These are increased systolic pressure, while the diastolic stays the same, a widening pulse pressure, and I've given examples here in the slide. For example, if you had a patient with 170/50, check on them again, it's 180/40. And then 200/20, you can see how there's a widening pulse pressure. And lastly is bradycardia. So these are imminent signs that the patient is having increased intracranial pressure that is really causing brain tissue death. These are late signs, so if you've seen Cushing triad, then you might have missed something in particular along the way. Let's talk about posturing with increased intracranial pressure. Posturing can occur with increased intracranial pressure. There are two types. Decorticate posturing is characterized with plantar flexion, knee extension, and arm and hand flexion, indicating pressure is interrupted in the corticospinal pathways. Decerebrate posturing is characterized by plantar flexion, knee extension, hand flexion, and arm pronation, indicating brainstem herniation. I can distinguish the difference between the two by associating decorticate posturing with cording someone because I visualize the arms and hands brought to the core of the body. Both these posturing are indication of increased intracranial pressure. The worst being decerebrate posturing because, again, that's impacting the brainstem. Now let's talk about an assessment with your patients that have increased intracranial pressure. There are two types of neurological assessments: a rapid neurological assessment and a complete neurological assessment. A rapid neurological exam is based on the emergent needs and client deterioration, which includes a Glasgow Coma Scale, level of consciousness, orientation, movement of arms and legs, pupil size, and reaction to light. The complete neuroexam includes level of consciousness, also known as a mental status exam, memory and attention, pupil check with use of Perla exam, that's where the pupils are equal, round, and reactive to light, cranial nerves, motor and sensory function, deep tendon reflexes, and cerebellar function. An important part of the neuroexam is comparing one side to the other to detect subtle changes in neurological functioning. Assessment of labs and diagnostics are important. Diagnostics and lab work is directed at identifying and treating the underlying cause of increased intracranial pressure. There isn't one lab to really test to indicate increased intracranial pressure. Serum osmolality like sodium, chloride, bicarbonate, proteins, and glucose monitors hydration status, and ABGs measures pH, oxygen, and carbon dioxide. Hydrogen ions and carbon dioxide are vasodilators that can increase intracranial pressure. So if the patient is acidotic, this will just add more insult to the injury of this increased intracranial pressure. CT and or MRI scanning is generally the first test. Other tests can include skull and spine x-rays, cerebral angiography that looks at cerebral vessels. A PET scan can be helpful in understanding the functioning of the brain, specifically glucose and oxygen metabolism and cerebral blood flow. An electroencephalography, an EEG, looks at the electrical activity of the brain. In general, a lumbar puncture is not performed because of the risk of brain herniation caused by the release of pressure. As you study, it is important to research what nursing assessment will be important before sending patients to some of these tests. In particular, diagnostics require stopping medications, checking lab values. So I would go back and research if there's any sort of nursing assessment that needs to be done prior for those patients to go down for any of those procedures. The plan and the goal for increased intracranial pressure is to promote adequate cerebral perfusion and minimize cerebral tissue damage. Let's talk about some of the interventions. The nursing interventions for increased intracranial pressure is assessing neurological status and vital signs every 1 to 2 hours and report any changes to the healthcare provider. Also monitor trends in vital signs like the respiratory rate. Because increased intracranial pressure can impact respiratory function, in particular if you're having pressure on the brainstem, monitoring respiratory status is imperative. Monitoring central venous pressure can also give you an indication of how much pressure is being placed on the body. An elevated CVP indicates too much fluid. And also increase the head of the bed by 15 to 30 degrees, or as ordered, to facilitate cerebral venous drainage. Again, it depends on what the physician orders, but the head of the bed usually facilitates venous drainage. Assess for bladder distension and bowel constipation, as this can increase intracranial pressure. Increase in stimuli can also increase intracranial pressure, so dimming the lights, making it more of a quiet environment is better for that patient. Avoid neck flexion and extreme hip or knee flexion, because this can also cause more pressure on the brain. Maintain fluid restriction as prescribed, and also if the patient has a drainage catheter via a ventral colostomy, keep the dressing over the catheter clean and dry and monitor for any CSF leakage. Administer medications to decrease intracranial pressure as prescribed. Osmotic diuretics like mannitol and Lasix are commonly used to decrease intracranial pressure. Corticosteroids like dexamethasone may be beneficial. Along with analgesics and sedatives. Antibiotics can also be indicated for specific infection causes for increased intracranial pressure, in particular like something like bacterial meningitis. Stool softeners are also important, again, to avoid increased intracranial pressure with any sort of straining or pushing. Advise the client to maintain head in a neutral head position and neck alignment, because again this can also increase intracranial pressure, so having a neutral alignment is important. For more details about information and understanding, use these links below that I have provided here to give you additional information. Next, we're going to talk about evaluating our desired outcomes. The overall goal for clients experiencing increased intracranial pressure is quick management of symptoms, provide support and comfort, provide therapies that are geared to bring intracranial pressure into a normal pressure, minimize cerebral tissue ischemia, and ultimately the client hopefully will return to the baseline of functioning, or at least we will assist them with meeting their potential for whatever causes there are. This concludes the presentation on nursing management of clients with increased intracranial pressure.